This is part 1 of the lecture Pancreatitis and Exocrine Pancreatic Tumors by Dr. Hisham El-Akkad, Professor of General Surgery at Ain Shams Medical School. By the end of this lecture, you should be able to state the etiology of pancreatitis according to given data and whether acute or chronic, set a list of differential diagnosis and choose the proper line of treatment, recall the severity scores of acute pancreatitis, detail the conservative treatment of acute pancreatitis, describe the different types of exocrine tumors, set a list of differential diagnoses for a pancreatic mass, explain the expected findings of investigations for a pancreatic mass, and justify your choice of a certain line of treatment for pancreatic exocrine tumors. More than half the patients who develop acute pancreatitis have gallstones. Most, but not all of them, have multiple tiny calculi. The exact pathogenesis is not clear. It was assumed due to temporary obstruction of the pancreatic duct by a stone at the common channel or by bile refluxate into the pancreatic duct with activation of its enzymes. Alcohol intake is the leading second cause in the West, but most of our patients have undetermined cause and the pancreatitis is said to be idiopathic. Hypercalcemia, either due to hyperparathyroidism or multiple myeloma, predisposes to the disease. Some viral infections, venoms, and drugs might precipitate acute pancreatitis. These drugs include non-steroidal anti-inflammatory drugs, thiazide diuretics, steroids, and others. Trauma-induced acute pancreatitis is mostly iatrogenic, especially after ERCP or pancreatic injury during surgery on or near the pancreas. With mild pancreatitis, there is only edema of the organ. If a phlegm forms, which is the necrotic part of the pancreas as seen in the CT, it is less than 30% of pancreatic tissue and is sterile. Severe necrotizing pancreatitis is characterized by a phlegm more than 30% or bacterial infection or both. Pancreatic fluid may fill the lesser sac and form a pseudocyst or pancreatic abscess, or may spread in the peritoneal cavity and cause pancreatic ascites if sterile or generalized peritonitis if infected. Hemorrhagic pancreatitis may occur in association with necrotizing pancreatitis. The pancreatic surface is the source of bleeding, but the digestive pancreatic enzymes might act on the other areas as well, with erosion of sizable vessels, like the splenic vessels, which usually lead to fatal bleeding. The pain is classically described as rapidly increasing to become severe and constant, often described as boring or stabbing, is partially soothed by sitting in bed and bending forwards while pressing against the epigastrium with the hands. Analgesics short of narcotics are useless. Nausea and vomiting are due to the inflammation, pain, but also due to duodenal ileus and delayed gastric emptying. Ileus and sequestration of fluid in the peritoneal cavity are third space losses, which together with vomiting might lead to symptoms of hypovolemic shock. The condition is more severe with hemorrhagic pancreatitis. The superadded infection, the picture of septic shock, might prevail. Fever of high grade in association with rapid deterioration in level of consciousness is a sign of sepsis. The degree of tenderness, guarding, and rigidity depends on the severity. With generalized peritonitis, the rigidity is generalized. Gray-Turner's sign and Cullen's sign are ecchymosis at the left flank and around the umbilicus, respectively. They occur due to hemorrhage in the retroperitoneum and spreading extraperitoneally around the flank. The signs are common with hemorrhagic pancreatitis, but may occur with any other cause of retroperitoneal hemorrhage. Serum amylase when over 1000 is diagnostic, but may be normal even in severe cases. Serum amylase is usually around 500 in other inflammatory abdominal conditions. Serum lipase is more specific than serum amylase for acute pancreatitis. CT with IV contrast is the main radiology study. Bulky pancreas due to edema with loss of surrounding fat planes is shown with or without phlegm. Fluid In lesser sac or generalized peritoneal cavity may also be apparent. Abdominal ultrasonography must be done to diagnose gallstones or acute cholecystitis as differential diagnosis for acute pancreatitis. Associated dilatation of CBD and intrahepatic ducts indicate CBD stone. Although many endoscopists are reluctant to do ERCP during the acute phase of pancreatitis for CBD stone extraction, on view that ERCP itself might induce pancreatitis or aggravate it. Yet evidence-based studies had proved that early ERCP sphincterotomy is attended with improved outcome. IV antibiotics, usually icarbapinum or a third or fourth generation cephalosporin, is used even before signs of infection. As the patients are intolerant to oral feeding, treatment includes NPO with or without insertion of nasogastric tube to prevent vomiting. IV fluid and electrolyte therapy often requires ICU admission in severe cases with hypovolemic or septic shock. Octreotide is a synthetic analog of somatostatin, which is an inhibitor of growth hormone, but is also said to inhibit pancreatic secretions. It is of unproven efficacy in treatment of acute pancreatitis, although it is still widely prescribed for this reason. The signs indicative of need for surgical debridement with peritoneal drainage include high fever, leukocytosis, air fluid level in lesser sac, and phlegmon more than one-third the pancreas. Culture of aspirate may verify superadded infection necessitating surgery. There are several scoring systems for assessment of severity of pancreatitis. The Ranson's criteria are the oldest and was specific to pancreatitis. The Acute Physiology and Chronic Health Evaluation 2, known as APACHE 2, is not peculiar to pancreatitis but could be applied to it. The modified Glasgow Imrie criteria is the most applied today. These systems are not only of prognostic value, as prognosis correlates with severity, but also are useful in follow-up of disease progress and response to treatment. You may pause the video to study the following criteria. Systemic inflammatory response syndrome, or SIRS, is a generalized inflammatory state that is not necessarily due to bacterial infection, but may be due to other acute illnesses like ischemia, shock, trauma, and immune disease. It is characterized by endothelial inflammation. This slide presents the signs of development of SIRS. SIRS may lead to MODS, which is multiple organ dysfunction syndrome. The development of SIRS is an ominous sign of acute pancreatitis. When MODS or septic shock develops, mortality exceeds 50%. Now we are going to speak about chronic pancreatitis. Alcohol-related acute pancreatitis tends to recur and ends up with chronic pancreatitis. Pancreatic duct obstruction by cysts, anomalies like pancreas divisum, post-surgery or ERCP, and cystic fibrosis may lead to chronic pancreatitis. Autoimmune diseases associated with chronic pancreatitis are primary biliary cirrhosis and primary sclerosing cholangitis. Idiopathic, unidentified cause dating since birth is rare. Early pancreatitis passes by two stages. At the early stage, the pancreas is swollen, edematous, and with areas of hemorrhage and necrosis. At later stages, the parenchyma becomes atrophic and multiple stricturing of the duct occur. Pancreatic stones or cystic dilatations develop proximal to the strictures. Chronic pancreatitis may be diffuse or focal. Focal chronic pancreatitis affects the head of the pancreas most and is usually associated with alcohol intake. Focal pancreatitis is almost impossible to differentiate from carcinoma without pathology examination, although PET scan could be helpful. With chronic pancreatitis, pain is either recurrent or persistent. It is the main highly distressing for the patient and is the main reason for surgical treatment. The pain is epigastric and typically radiates to the back. It is severe and often could not be relieved except with opiates. Food and alcohol make it worse. With chronic pancreatitis, plain X-ray may show calcification of the pancreas or may show radio-opaque stones. Abdominal ultrasonography is of little value to assess the pancreas, but is done to rule out other associated diseases. CT with double contrast is useful to assess the extent of the disease, identify cysts and focal lesions that might turn to be tumor. MRI is used like CT, but is said to give superior results. ERCP is used mainly for therapy, stricture dilatation, stone extraction, and pancreatic duct stenting can be done endoscopically. Treatment for chronic pancreatitis may be conservative or surgical. Alcohol aggravates the pain and should be abandoned. Fat-induced steatorrhea is reduced by fat restriction and diet. Antioxidants suppress the inflammatory reaction. Exocrine pancreatic enzymes in the form of powder is sprinkled like salt on the diet. Opiates may be needed, but chronic use may cause addiction. Therefore, celiac block is a common alternative. It is effective for about 3 months. Blood sugar is very fluctuant and is difficult to control. Severe constant or relapsing pain might mandate surgery. For pain, the operation needed is resection of diseased part or whole pancreas. Total pancreatectomy is followed by severe diabetic condition and, unless closely managed, might lead to grave consequences including mortality. Stones and strictures might be managed by stone extraction and anastomosing the duct to the jejunum, whether following partial pancreatic resection or without. A pseudocyst over 5 cm can be anastomosed to the stomach or jejunum. Pancreatic fistula usually needs partial pancreatectomy with or without pancreatic jejunostomy. A Whipple operation is done for pancreatic head focal lesion when a tumor could not be ruled out. Thank you. We shall continue in part 2.